You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. And today we are joined by ONS members Meghan Coleman and Alison McDaniel, who together earned first place in the inaugural ONS Hackathon for their project to solve unequal access to germline and somatic biomarker testing. The ONS Hackathon took place over 2 weeks in November 2020 and gave nurses a platform to develop innovative ways to address challenges in the delivery of quality cancer care. For more information on the ONS Hackathon, read the press release at the link in the episode notes. Thanks for joining me today, and congratulations on your recent accomplishment.
Thank you.
So to start us off, I would like you to tell us a little bit about yourself as far as where it is that you work, what you do, and why you applied for the focus area that you did when you saw the application for the hackathon.
Hi, so this is Meghan Coleman. I'm a doctor of nursing practice. I am here in Abington, Pennsylvania. I work at the Asplin Cancer Pavilion, which is part of the Sidney Kimmel Cancer Center, part of Jefferson Health. I see patients daily and very often am part of the process when they are starting their treatment. I follow them through their course of treatment, providing psychosocial and clinical care, and then often into survivorship or whatever course their disease takes. One of the reasons that I chose the area of biomarkers was because we are really moving to a place of treating patients individually, or better known as precision medicine. And for that fact, there are so many things that happen when patients are starting up their treatment. So to me, getting the diagnosis and initially having those biomarker tests really starts off the process of their cancer care trajectory. And it's important for them to know what these tests mean, what their treatment options are, and what we can do to facilitate and make this as easy on them and their care providers. So that is why we ultimately came up with the idea of EQUIP.
I'm Alison McDaniel. I'm a manager of navigation for Ochsner Health Cancer Service Line in the New Orleans area of Louisiana. So before I was managing the navigation program here at Ochsner, I was a nurse navigator myself. And I think that the reason that this topic appealed to me so much is, as oncology navigators, a lot of our job is just filling in the pieces in reading between the lines for patients. And the area of targeted medicine and evidence-based practice and biomarker testing is all a very complex, almost like learning a new language for some of these patients. And the nurses and clinical staff and providers basically have to educate them on the importance of it, the reasons behind it, why it's beneficial, and really explain what the patient should expect throughout the process. So I felt that this was something that I was very familiar with. I was very comfortable with speaking to patients about, but also I have learned over the years just the necessity of it and the benefit of it to patients. And it's such an exciting science, and it's growing so much every year. And I think it's definitely the future of cancer care. So it's definitely a topic that I'm very passionate about and that interests me quite a bit.
Great. Well, thank you. I'm going to ask Alison first. Can you just walk us through participating in the ONS Hackathon, just what you thought of it and just a little bit of an overview?
Yeah, absolutely. So as you mentioned, it was a 2-week program. When we were asked if we wanted to participate, the kind of description we were given is that it would be 2 weeks with about 4 or so sessions that we would be asked to participate in, and kind of a little bit of an overview of what a hackathon is, but not a ton of kind of description of what we were going to be asked to do, which in hindsight, I think was the only way to do it. But at the time it was a really neat experience because you start the process, day one of the 2 weeks, and you don't really know what you're expected to do. You don't know who your team is. You don't know what your topic is. It's kind of like you're blindly going into something that you've agreed to. And then as the days go on, you get more and more overwhelmed because you're not sure if you're doing it right, because there's not a ton of, Meghan and I kept saying, I just wish I could see an example of a completed project, because then I would know to go with it. But that's exactly what they don't want to do. They don't want to give you a completed project to model after, because they don't want you to model after anything. They want you to be as inventive and creative as possible and take it where you think it needs to go. So I think the whole 2 weeks was a lot of just critical thinking, a lot of research. Meghan and I would go off on our own, do some research, come back together and talk about what we found. We would message each other throughout the day. I just had this great idea, it just came into my head. Or last night while I was trying to go to sleep, I thought of this. And so it was just kind of like a great exercise of the mind, especially for an oncology nurse, because we think about all this stuff all the time anyway, but we got to really dive really deeply into this topic. And it kind of consumes you in a way for 2 weeks. Might have just been 4 sessions that we had to attend, but we really thought about it all the time. And by I would say, I don't know, Meghan, maybe day 7 to 10, we really started to be like, okay, so this is what this is about. This is what we're trying to produce and come together. And our project really took shape. And then the rest of it just happened so fluidly and so easily, because we had done all that prep work and we had done all that thinking, critical thinking on the front end. And the actual project itself and the presentation, it was the least difficult part of it, because all of that thought that we put into it when we didn't know what we were doing, it ended up producing something really concrete just without us even trying. It was a really neat experience. It's hard to explain, but it definitely makes you think in a way you haven't had to think in a while or before at all. And it makes you feel very accomplished at the end, because you went through something that you kind of didn't have direction on, and you produced something really impressive.
Well, Alison, I can hear the excitement in your voice just on how fun and interesting and creative this process was. So I'm excited to hear about the whole project and everything that you guys worked through as you did this. So Meghan, I am going to ask you now if you can give us kind of a high-level overview of the project that the two of you came up with, evidence-based quality understanding in pathology, or EQUIP.
Absolutely. What we came up with was an idea on how to get equal access, where we were trying to reduce the disparity between a couple of things. One, how patients access their information, how providers get this information, and how we could possibly streamline it so that anyone who was having biomarker testing could have equal access, whether they were living in a rural area or an urban area. And our idea really came to try to bring together both the patient and the pathologist at the very beginning. So what we had proposed was that there would be a QR code that would be similar to something like you see when you have a supermarket tag, where you can have your information on that QR code at the time when your pathology is being sent off. And that QR code would be attached to the pathology, as well as the patient would be given a copy of that. There is a long time between sending the testing for biomarkers and genetic mutations. So trying to decrease the other information that impacts that was our goal. So within that 14 days of waiting, the patient could still proceed forward with trying to find an oncologist and be able to bring the ultimate results of the pathology to them, because they don't know who they're going to see before they have their pathology. So the goal is to have the QR code then upload to an app, which we named EQUIP, as you spoke before. And this was an evidence-based quality understanding in pathology, so that the pathologist, the treating physicians, the patient, family members, nurse navigators, medical oncologists, radiation oncologists, all could access that information at the same time. wherever that patient went. And then additionally, our hope was on the back end that we would help to bring together clinical guidelines that are currently in use, but not everyone uses them or has access to them. And there's also some disparity in both rural and suburban academic and medical centers, whether they're using the most and the best latest technology. So our hope is that by using this code, helping to keep track of a patient's diagnosis and the biomarkers that were being tested, they would be able to have instant access to that information, as well as the most up-to-date clinical guidelines that would inform decision-making.
That's a lot. You guys really thought that through. What an amazing piece of information that would be so powerful for our patients to have access to, especially in our world today where things are so transient, and for one reason or another, a patient might have to move, but to be able to have that and that they understand that information and could readily give that to a provider wherever they are. That's just really an amazing idea. So, Alison, I'm going to ask you if you can talk us through the first part of this and what you guys would have said or did say was the problem and how you came to kind of make your problem statement as far as what was the problem. Were there different players that were involved in that problem or who that problem was affecting?
We were given a topic to target, and then we were also given a persona. And this was just a patient description, a little very brief scenario of a patient that we could use to kind of tailor our project problem statement. We were assigned a gentleman named Wayne, who had just found out he had a mass in his lung that was found by a routine chest x-ray. Just a normal, everyday guy has Medicare. He's taking care of his wife, who has just been diagnosed with dementia. A lot of his kids live out of state, so he doesn't have a ton of other support. It was just a very brief, it didn't tell us what happened to Wayne. It didn't really go very much into detail, but we were able to kind of take that and run with it. And we started thinking about, okay, well, say Wayne lives in a rural community and his hospital doesn't have access to the most up-to-date evidence-based practices. And Wayne's PCP doesn't know what to do with this lung mass and this information. And by the time we figure out that he has lung cancer, maybe it's been 3 weeks. And without the correct testing, Wayne might end up getting all this chemotherapy that he could have avoided if he had been diagnosed with any sort of targetable mutation. He might not be able to do the chemotherapy and care for his wife. We kind of went down this rabbit hole of worst case scenario and then what would be the best case scenario. And so we decided that one problem that people like Wayne might experience is that when you get this diagnosis and you don't know what to do next, or you're in a rural community and the providers you're seeing don't know what to do next, how can we link Wayne and his medical team to experts in this field and help expedite the advice that they need in order to get Wayne the treatment he needs and the workup he needs to figure out what's going on? And then on top of that, what would be the best scenario for Wayne as far as treatment goes? And of course, that would be something outpatient that didn't involve a lot of his time, that wouldn't affect him with a lot of side effects, that would help impair him from caring for his wife. And I think that's the beauty of these targeted therapies and these next generation sequencings that we've been talking about, is a lot of them lead to additional treatment options that might not have even been on the table for these patients, and they certainly wouldn't have known to ask for. And by linking these providers with experts in their field, I think you can open up this whole realm of additional options for the patient that make their quality of life better and their access to care better.
Thank you. That was a great description and really kind of laid the groundwork for us on your project and who the players are and what role they play in all of this with the patients that all of the nurses that may be listening to our podcast are working with. So Meghan, I'm going to ask you the next question. Why is pathology crucial to caring for patients with cancer?
So I'm going to start off in terms of where our patient and his diagnosis was heading towards, and that was lung cancer. And it's important to know some statistics. So the American Cancer Society has estimated that in 2020 alone, there'll be 228,000 new cases of lung cancer. And unfortunately, there'll be 135,000 deaths from lung cancer. So as you can see, this is a devastating disease. And in the past few years, there have been approaches in the way we treat not only lung cancer, but all cancers, and that is through very specific molecular tests. Right now, there are 19 FDA-approved immunotherapies available for the treatment to very specific, very precise medicine. In lung cancer, there's 9 molecular tests specific to lung cancer, which means that if we can treat the patient based on how their cancer will react, we will have better outcomes and improve survival rates. So one of the issues that we were trying to build in, and Alison touched on that, is there's not yet quite clear guidelines on what every biomarker test should be ordered. And in addition to this very important testing that we can do, there's a disparity in accessing these tests in a timely and standardized manner. So what we're finding is that precision medicine using biomarkers can improve patient outcomes.
Well, that's definitely an important thing and something that we really want to happen. And especially in the climate and the healthcare where medicine is right now, with as fast as new treatments are coming out and the immunotherapies like you mentioned and things like that, that are specific to the biomarkers and how those outcomes can be better for patients if they have this more in-depth and detailed testing. It's definitely something that we need to make available to all of our patients that we have, and makes this having to be able to have good access for all patients in order to get the best treatment for their diagnosis. So Alison, this next question is going to go to you. What are the barriers for biomarker testing? I'm sure that as you guys were going through and you found your problem statement, then you needed to find out what are the barriers to, well, we'll get to it next, but get to the solution that you have. So what were some of those barriers that you guys identified?
So as Meghan mentioned, there are quite a few different mutational studies you can perform, just for lung cancer, let alone all these other cancer diagnoses that we're finding more and more ways we can treat patients comprehensively without just blanket chemotherapy regimens. But not all pathology departments can perform these tests. I mean, they're coming up with new ones every year. They're changing the approval and the insurance coverages month to month. So a lot of pathology departments just don't have the ability to get the equipment needed or the staff needed to perform these tests. So a lot of times it's a send out lab that we have to send the specimen out to another place like Mayo Clinic or another bigger institution that is capable of performing some of these tests. So that, of course, takes time. Normal turnaround can be 2 weeks, maybe even 3 in the worst case scenario. And even more so, just a lack of education in some of these smaller, more rural medical centers. The pathologists certainly in a lot of these centers might not feel empowered to make the decision on what testing is needed on their own. And so that might fall to the medical oncologist. So if you think about a timeline here, a patient gets a biopsy, maybe like Mr. Wayne, it was ordered by his primary care doctor. That specimen is received by pathology, takes a week to find out that Mr. Wayne has lung cancer, takes another week for him to see an oncologist at best. And then that oncologist orders that additional mutational studies, which then takes another 2 weeks at best. So we're looking at a month where Mr. Wayne's just sitting there needing treatment and not getting it. So I think that the biggest barrier is just access and knowledge. And that's what we were hoping with Equip to be able to fix, being able to connect people in a way that empowers them to make these decisions quickly and facilitate understanding what pathology departments can perform these tests and where you can send it and how you can place that order and how you can get insurance to approve it quickly and get that patient from A to B as in as expedited a manner as possible.
I'm sure that folks listening in on this today are probably shaking their heads going, oh my goodness, yes, I can remember this patient waiting for so long and this patient that we had problems in getting the insurance approval, and how folks can relate to everything that you were talking about. Meghan, so why don't you tell us about the solution that you guys came up with for your project?
Yeah, so the solution, as we've sort of alluded to, was the use of a QR app that would bring both the patient and the pathologist to our app, which we named EQUIP, Evidence-Based Quality Understanding in Pathology. And by bringing both the patient and the pathologist together, we now would be able to help navigate what the best clinical practice would be for both testing followed by treatment. Our ultimate goal was to have an expert panel that had a pathologist, a medical oncologist, a navigator, a financial coordinator, and a patient representative to sort of round out the team of experts and help guide the patient if there was an issue that was identified that would be a barrier to care. The other thing that we were thinking about was that this would be a great place to sort of be for lack of a better term, a data warehouse for analytics. When Alison and I were working on trying to find out about insurance and insurance approval for these very specific tests, we were getting some information to suggest that primarily Medicare and Medicaid and the private insurance companies were covering the costs of this, but we weren't getting a great picture of what was happening to those who were uninsured or had limited insurance access. So by bringing all of this information together, we were hoping in the future it would identify barriers for future care. So we were really hoping that having all of this data in one place and having experts in one place that both the patient and the medical team could access through this QR code, that they would receive better treatment and have some of the barriers identified and give them a way to work through them right there and then.
That's really interesting and just amazing how you guys thought that all through and came up with that solution. Alison, I'm just going to ask you, I know that you guys we've talked about a lot of the different pieces of it, the problem, the players, the barriers, and we just heard about the solution. Can you kind of give us just an overview of how it actually would work and how you would see EQUIP working for maybe your patient Wayne?
So let's say that Wayne does end up getting a biopsy, that the pathologist in a community health center that is enabled with EQUIP gets a preliminary diagnosis of non-small cell lung cancer. So he immediately accesses his EQUIP app, puts in the pathology information that he has come up with. If he has the capability, he could even upload images of the slides that helped him diagnose the patient. And then EQUIP would link him to a panel of experts, which, as Meghan mentioned, would include a pathologist. It would also generate that QR code on the path report and route that QR code to the patient. And that QR code would be kind of our way to check on the status of that patient's evaluation with that expert panel, as well as the status of the testing that's recommended and any other things that are then put into place for his treatment journey. So the expert panel might come back to the pathologist in 24 hours and say, we think you need these molecular testing orders, and you can do that through the hospital that you're, in a town that is a little bit bigger. Maybe there's a state-run hospital or a privately owned hospital that performs these tests that you can ship the specimen to. This is the order you need to put in, and this is what we think you need to do. And then that pathologist can be equipped to take care of that himself or herself for Mr. Wayne, instead of us having that delay we talked about where he needs an oncologist that will then make the decision to order those things. In the meantime, while Mr. Wayne is waiting for his results, he can use that QR code, or maybe Mr. Wayne's kids can show him how to use that QR code to check on the status of things. He'll be able to know that that's been sent for these additional tests. Maybe there's a link next to those additional tests where we can show Mr. Wayne some education on why those tests are being done in layman's terms. He and his kids can talk about the reasoning behind it and what being positive versus negative for them would mean, and hopefully get him an answer much more quickly than we would if we were waiting for another doctor to place these orders. And Mr. Wayne feeling much more educated about the process. So the waiting doesn't feel quite as much like a limbo and more like a progressive step in the right direction. Moreover, as we kind of expanded this past pathology, we thought, okay, so say he does have a mutation that's targetable by a medication and he gets set up with an oncologist in another hospital or in another private practice, that QR code he can bring with him, the app he can bring with him, he can have access to that pathology report to give to his oncologist. And that oncologist, if they are also using the app, can get the same recommendations from a panel of experts about what treatments are best because of this mutation. Mr. Wayne can get education on those treatments. We even talked about maybe linking him with like a support group chat where other patients who are linked to the app who are getting these medications talk about side effects and different things. Again, this is a hackathon, so we could be as innovative as we wanted. We could make this as big as we wanted. So then we went into the thought of, okay, we're nurses. What do nurses need that we could provide in this app? You know, a lot of these innovative therapies, sometimes insurance drags their feet on authorization. Maybe we give nurses and clinic staff some education on the best way to get the authorization quickly, some of the prior auth things you can do, the best way to code these, what diagnosis codes are the most likely to get approved quickly. Maybe there's still a high copay for Mr. Wayne. We could link them to a social worker in the panel of experts who might know about some patient assistance funds or a nonprofit that can help him. Maybe Mr. Wayne needs help with transportation to and from his doctor's appointments. That might be something the app can assist with. Just using that panel of experts to link these rural community patients and medical providers with resources that maybe were always available to them, but they just didn't know existed. And all of that can be communicated through the app and be provided to everyone in one comprehensive location.
You guys truly thought of everything. And I liked your comment about having his kids be able to help him out with figuring out the QR code if it is on the app.
Yeah, that was something we thought about too. You know, one of the things in the persona we were given is that a lot of his kids live far away. Well, what a better way to connect your kids to your medical information instead of poor Mr. Wayne trying to relay what all these doctors are saying. They can get a copy of that QR code and they can download the app too, and they can be a part of that and get access to all the same information with his permission, of course. But I think that's also a problem a lot of times is patients are trying to understand everything, not only understand everything for themselves, but also have to then tell their family members, even more so with COVID, since, you know, visitor policies have changed. You can't always bring loved ones with you. There's just a lot of pieces there that I think we could tackle pretty easily.
So I think that is excellent, the way that you guys have thought about all of those different pieces. And I do agree that you've thought about the patient, you've thought about the different providers that they're going to encounter and their family members, and the fact that they might be far from each other. And I also think that the way you guys have thought about this being a community-based access for community rural patients as well as those academic center folks, because I think that's where we might see some of our disparities with patients, and being in those rural settings or those smaller community settings that might not have access to quick pathology reports or things like that, where they can get their results quickly, as well as knowing and having the access to what are evidence-based treatment guidelines and what are the gold standards for, you know, their current diagnosis and the results of that testing that they had done. So you guys have really done a great job with all of this. Meghan, I'm going to ask you our next question. So as you guys were processing all of this over those 2 weeks and, you know, spending time back and forth with each other. And as Alison, you mentioned earlier, you know, you'd come up with an idea sometime during the day and you'd text Meghan and just say, hey, I just thought of something else. Did you ever talk these ideas through with any colleagues or patients before you had your final pitch that you gave to the judges?
Yeah, this was such an amazing experience over the 2 weeks, and the flood of information and the excitement as we built this potential application for patients. It was a lot of fun. And as we were moving into the end and about to get ready to do the pitch, I happened to be sitting with one of my breast cancer patients, and her name was Pam H. She is an older woman, fit and trim and smart as a whip, still working in her late 70s. And as we were chatting about her breast cancer, she said she was having some concerns about the effectiveness of the treatment that she was currently receiving. And she said in passing, well, but I always have the PIK3 mutation, and I know that I can fall back on that treatment. And it stopped me because it was so appropriate to where our project was going. And I said, do you mind if I talk to you about this? And she was like, no. And so she could hear my sense of excitement. And I said, what would you think of carrying around this app or having a QR code that you could give to all the different people that you were seeing? Because she was really advocating for herself and seeing different providers for their perspective. And one of them was clinical trials. And I said, would you find there would be any utility to having you carry around your information? So as you went to each of these different places for prospective treatment, would this be helpful? And she was so excited about it. And she thought that it would be a great idea. And just the fact that she could take it's sort of, in some respects, a traveling medical record is how I feel, except it doesn't need to necessarily integrate with a hospital-based system. So she could have this information so that she could present it in a timely manner to whoever she was seeing. And she really, really was excited for me. And as a side note, I told her that we were doing the pitch the next day, and I was off the following week. When I returned, my email was flooded with congratulations from her. And then she had all sorts of places that she wanted me to spread this information. So I certainly had to check in with Michelle from ONS and just make sure that this was okay. But she had reached out to Cure Magazine, and she had reached out to my hospital system to make sure that they were aware that we had won this ONS Hackathon, which speaks to why I think she was so excited about it. She was also advocating not only for herself, but for other patients who might not know that this is really critical information, and that she had some testing done on her cancer cells, and that there was a very specific biomarker that could give her another form of treatment. People might not have that information, and they might not know to advocate for themselves to get that information. So it was a reaffirming going into that pitch that she felt that this would be very practical, usable, and she also felt that just having the code and then an app would be a lot less cumbersome than carrying around her very large folder of articles and information. She was a really great advocate for herself. And that gave me inspiration moving into the pitch, that it was something that could be used and used with great success.
That's really great to hear. And what a great real world application before you guys even had your pitch. So thanks for sharing that with us. Alison, what did participating in this hackathon mean to you? You know, especially right now during all the craziness you and all the healthcare workers are going through right now with COVID and everything else.
Well, I've worked with ONS on a couple things now, and I always value the experience so much because it connects you with other amazing oncology nurses like Meghan. And it allows you to really think and take a minute and just like see things a little bit differently, be a little bit more creative than maybe you get to be in your everyday job, and just mix things up a little bit, especially this year, just given in 2019, I would have gone to a couple of conferences by now. I would have gotten to network with other nurses face to face in different ways around the country. And obviously 2020 just hasn't gone that way. And we've been so inundated with the constant changes in policies and rules and regulations to protect us and our patients throughout this year. I think it's been nice to have that 2 weeks where we really got to just be innovative, creative, kind of leave our daily routine a little bit and really look at things in a different way. You know, it was a stressful 2 weeks. It was a lot of hard work. And like I said, you kind of just like thought about it all the time because you just wanted it to be good and you wanted to create something worthwhile. But it was such an sense of accomplishment that we wouldn't have gotten otherwise. And it was such a nice way to just have a little difference in life for a minute. And just getting to meet not only Meghan, but the ONS and HackWorks set us up with some amazing mentors that kind of helped us streamline our thoughts a little bit and troubleshoot some of our thinking and our ideas, and would this work? Would it not? What are we missing? And those mentors were amazing. I felt so honored to even get to speak to them, let alone get their advice and create something with them. So that was really exciting. I think just overall, it was just such a nice reprieve from the day-to-day life that we've had this year, and really got us to do something that there's really not many other ways you could have gotten an opportunity like this.
Thank you. That's really a great way to put it. And just to hear that it was something that gave you an outlet and something else to think about and something to be creative with. Meghan, did you ever consider yourself an innovative nurse?
It's an interesting question that you asked me, because when I was working on my doctoral project, I did bring it to the National DNP meeting, and I did win the Innovative Nursing Award for my clinical project. So I think I do know that deep within me, I want to innovate. I am able to innovate, and I have the ability to do that and produce something because of the background that this is all for our oncology patients. And when I was 17, my father had AML and eventually passed from that. And from that time, this has sort of propelled me forward to constantly be trying to challenge myself and challenge what we do and how we treat our patients. So I do feel that there is some innovation in me and a little fire in the belly that I want to do things and do things better. And I want to set forth a way to try and go about doing that. And ONS for sure has been a constant place for me to try and cultivate that innovation. And I've, as Alison had said, worked on several projects with them, and they're constantly have the oncology world in their scope. And not just the patients, but better care for nurses and better care in the way that we treat family members and best practices. So I think that I do have some innovation in me, and having places like the ONS Hackathon to help cultivate that, as Alison was saying, has been a great relief in this very trying 2020 year.
Well, thank you. I think you're both very innovative nurses, and I'm excited for what you guys have shared with us today. I think that as nurses, we talked a little bit about this before we even started recording. Just, we talk to our patients and come up with ideas every day when we're working with our patients or with our colleagues. And, what would you think about doing this? Or maybe if we change something this way. And I just don't think that we think of ourselves as innovative and innovators. And we really, really are. And I think this definitely was an exciting way to show that and to get that out there, and really to encourage other nurses to consider themselves that way and to realize that they do creative things as well. To finish us up, I just have two questions that I'd like to ask you guys, and I'll ask you, Alison, first. What is something about biomarker testing that's not often discussed, but you wish people knew more about?
One of the things we talked about a lot, and this is really for oncology nurses as well as just patients or people that don't know a lot about oncology, we keep talking about our example of Mr. Wayne and all of the things that QIP can do at the time of diagnosis. But one thing that always has to be kept in mind is when a patient maybe their cancer recurs or their cancer progresses, that biomarker testing, repeating that testing in any way we can, is still very crucial, because cancer is really intelligent. We don't want it to be, but it is. And it learns how to work around pathways that we once used against it. So just because there's a PD-L1 mutation at the time of diagnosis doesn't mean that 3 years later, when the patient has progressed, that a PD-L1 mutation still exists in all of the areas where the cancer exists, or that another mutation hasn't appeared that we can use to our advantage. So I think as nurses advocating for biomarker testing and these kinds of tests and mutational studies at all points of cancer care, whenever a treatment decision it needs to be made, is really important. We can't just let it go to the wayside once we've done it once. It needs to be in the forefront of our brains constantly as the patient progresses through their treatment and perhaps goes away for a while, but has to come back, unfortunately, and go through all of this again. Meghan, I would like to hear your opinion too, though, of what you maybe have thought of.
I would just say that the utility of biomarkers is increasing. And as Alison was speaking, I was thinking about the book, The Emperor of All Maladies by Siddhartha Mukherjee. And in that book, he sort of goes across the span of how we're treating cancers. And I'm bringing this up because I think that right now things are happening very quickly and treatments are changing very quickly. And so I don't think we realize how precise the medicine can be. And these biomarkers are heading and directing us in that direction. So just the utility of these biomarkers and what I think will hopefully increase in utilization has really impacted the way we have to approach our patients.
Thank you. What are resources for patients and providers wanting to learn more about this aspect of healthcare?
There are some resources out there for patients and providers. ONS, of course, has some guidelines. You can also direct to the National Comprehensive Cancer Network, the NCCN, also has a great resource in terms of what biomarkers we should be testing for each disease site. And also the Clinical Association of Pathologists do also have a set of clinical guidelines. And I think they're important that if nurses or providers or patients are struggling or looking to make sure that they are following and getting the best care, those would be some of the resources that I would recommend. And of course, eventually we would love to see those wrapped up into a QUIP. So more to come on that.
Yeah, when we were kind of thinking about who we'd need buy-in for this to work, those organizations were on the top of our list. You know, College of American Pathologists dictates a lot of recommendations. NCCN, of course, is kind of the gold standard for treatment recommendations based on those biomarker tests. The American Cancer Society, ONS, all of these amazing organizations coming together and in agreement on what needs to be done for these evidence-based practices, and having that all tied up in a nice little bow and an app for these patients and providers would be an amazing accomplishment. Also, NCCN has done a lot of work with patient guides and patient education, you know, how to put this stuff into layman's terms and make it understandable and not terrifying. They do a great job of that. And, you know, why reinvent the wheel when these things already exist? You just need to kind of gather them all together. So definitely think all of those organizations Meghan mentioned are top of my mind as well.
Well, I just want to thank you both for your time today and just also congratulate you again. What an amazing project you pulled together and worked through, and just, it's wonderful. I don't know what else to say about it, to be honest. But I appreciate that you took some time to talk us through this and just to hear both of you and the excitement and the passion that you have for your patients and for the care that you give, and how you thought about your colleagues too, and just how important it is for them. Do either of you have any final comments that you'd like to give today before we sign off? I
would just like to give props to ONS for devising this ONS Hackathon. My husband is a computer programmer and he has done hackathons. And in my mind, it was always a computer science type of initiative. And for ONS to take the lead and do in itself an innovative solution to trying to get people together to hash out ideas and try and affect change for the care that we give to our patients, as well as the collaboration we have with our colleagues, was a tremendous thing to be a part of, and certainly could not have pulled this together without the work between Alison and myself. It was such a great experience, and I have ONS to thank for that.
Yeah, and I would also give a shout out to HackWorks, which was the group that kind of facilitated the entire project and kind of gave us guidance on, they gave us the tools to create concept boards and get our ideas organized and linked us with our mentors and just ran the show. And it made it much easier to understand what was expected, to have those resources. And they were very communicative and they kept checking in on us and everything. So we felt very well taken care of as we, struggled to stay afloat in those 2 weeks of intense creativity. But I would do it again in a heartbeat. I think it was just a great experience. I encourage everyone who wants to participate next year.
Well, thank you both again. Congratulations, and thanks for joining me today.
Thank you.
Thanks for having us.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.